Hi, everyone. For those of you who don't know me, my name is Minji Kang. I'm one of the third year ID fellows that will be graduating in about 3 weeks or so. So today I'm going to be presenting about COVID-19 in children. So I have no financial disclosures. So today I'll be talking about the epidemiology, the transmission, the risk factors, the clinical presentation and management and outcome in children with COVID-19, as well as the multisystem inflammatory syndrome in children. So starting with epidemiology, so I'm sure as you guys may have heard already, there has been relatively fewer cases of COVID-19 among children compared to cases among adult patients. The proportion of cases that have occurred in children from various countries have typically ranged within like 1 to 5%. And according to the current data, in China, it was reported to be about 2.2, in Italy about 1.2, and in Spain about 0.8%. Here in the US, the first pediatric case was reported on March 2nd, and since March 5th, there's pretty much been pediatric cases that have been reported daily. This is data that I obtained from the CDC website that's up to date as of this Monday. And there's currently 67,436 pediatric cases among around like 1.4 to 1.5 million. So it's around the 4.7% range here in the US. But in comparison, there's about 22% of the population that makes up infants, children, and adolescents, basically under the age of 18. So 18. And those that require hospitalization is even less. There's approximately 223 hospitalizations out of 266,023. So that's less than 1%, so 0.9%. And as you can see from this chart here, the blue represents 0 to 4 years old, whereas the pink represents 5 to 17 years old. And it constitutes pretty much a very minuscule amount of hospitalization here in the US. And this is data from Morbidity Mortality Weekly Report from CDC that's from February 12th to April 2nd, so a little bit of an older data. But here, it shows kind of the age distribution among the pediatric population and their hospitalization. So up until about April 2nd, there was a total of 2,572 pediatric cases. And among them, 747 cases, the hospitalization was available for. And as you can see here, about 147 out of the 745 were reported to be hospitalized, with 15 admitted to the ICU. So those that kind of require ICU care is also much less. And children less than 1, as you can see by this dark blue bars, required by the light blue bar, and then and this blue bar required had the highest percentage of hospitalization, accounting for about 60, and it was 62% hospitalized among this population. And I'm sure you guys have heard about how COVID-19 has disproportionately affected certain minority groups, and it's pretty much similar in children as well. The red bar represents Hispanic, Latino, and the purple bar represents African Americans. And as you can see, they constitute majority of COVID-19 diagnosed among children under age of 18 here in the US. And this is the confidence study that was published in New England Journal of Medicine in early May, and it basically looks at 100 Italian children who were seen in the emergency department in Italy, and then they compare it to 3 other studies, 2 of which are from China, Liu and Dong et al., as you can see on the second and third columns, and then the CDC Morbidity Mortality Weekly Report that had data up to April 2nd. And here, the actual median age range seems to really depend on which country. And in Italy, it was around 3 years old, whereas in China, it was around 7 years old. Whereas our data shows the age range to be around the median age to be around 11 years old. Yearly and the actual age distribution seems to differ widely as well. Where in Italy, those that are less than 1 accounted for about 40% of the pediatric population that was diagnosed, whereas here in the US, it was about 15%. Consistently among among Italy, China, and the U.S., male boys seem to be disproportionately affected, with about 55 to 60% of the pediatric population noted to be boys. Here in San Diego, the pediatric population, there was about 586 pediatric cases out of 8,837. So that's about 6.6%. So a little bit higher than like the 1 to 5% range that I was mentioning, but kind of still within that range. So the question is, why are children affected less? And there's been a lot, there's been various hypotheses that's been thrown around. Not only do less children seem to get diagnosed with COVID-19, but even when they do get the disease, they seem to have less severe disease with fewer children requiring hospitalization. So some postulate that it may be just because children have young immune systems and may not have the aggressive immune response, like the cytokine storm that we see in adults. Some just postulate that it may be just because we can't really determine the true burden of disease because children may present differently, whether it's asymptomatic or with atypical symptoms. So children are just not getting tested early enough. And there's been some who say that it may just be because early school and daycare closures may have mitigated the disease burden in children. So now moving on to transmission. So this is once again from the confidence study that compared Italy versus China versus U.S. data regarding the pediatric patients. And as you can see here in the U.S., on the last column here, most cases that were diagnosed with in children are from the household exposure. So that accounted for 91%. The rest of the 8.7% are actually from travel related. In China and Italy, the household exposure was not quite as high, but did constitute majority of the exposures. There has also been some nosocomial transmission that's been reported, particularly centered around pediatric dialysis unit. And interestingly, many reported in the nosocomial outbreaks were asymptomatic, but did have seroconversions. Regarding children as transmitters, in this study that's coming from France, there was one pediatric case where this child visited 3 different schools while symptomatic, but among like around 180 or so other children who were exposed to this one child, there was 0 cases. And so there's been kind of questions about, do children just not transmit the virus as efficiently? And it's pretty unclear as to the role of children in transmission. And in this study, they looked at viral shedding among children, 110 children that were diagnosed in Wuhan. And as you can see, the median period of viral shedding was noted to be about 15 days from the illness onset. And then this was actually shorter in asymptomatic patients at about 11 days. And in symptomatic patients, it was about 17 days. There was a separate study that also reported kind of prolonged viral shedding in feces in pediatric patients with coronavirus disease. The red The red represents throat RNA positive, and the range seems to be pretty consistent, kind of within that 10 to 15 range. The yellow which is positive fecal RNA, seems to range between like 23 to 30, so about up to like a month. But obviously, what this exactly means is pretty unclear. And overall, the duration of viral shedding seems to be variable. Um, though those who are symptomatic appear to have longer duration of viral shedding. And in children, it's really unclear what the optimal duration of home isolation should be, but the current recommendation is pretty much the same as adults. And I think two other methods of transmission that needs to be accounted for in children is vertical transmission, as well as possibility of transmission by breast milk. And in terms of vertical transmission, in most women who do test positive for SARS-CoV-2 in nasopharynx, their most vaginal fluid, amniotic fluid, and placenta specimens have been negative to date. There has been a few reports. This was published in JAMA, I believe, in March or so. And in this case, there was a mother who was in her third trimester who basically was admitted with respiratory difficulties in the setting of COVID-19. And this chart basically represents a mom's laboratory data and PCR data. And as you can see, she was PCR positive, as well as SARS-CoV, as well as serology positive. And then subsequently, she had the infant delivered by C-section on February 22nd, and she was diagnosed on January 28th. And on the date of her delivery, they ran some labs, and some of the things that they noted were mild transaminitis and some mild inflammatory markers, IL-6 and IL-10. And she was also noted to have elevated serology results. And they kind of postulated that this may be signs of possible vertical transmission. But I think what's important to note is that this child was PCR negative on 4 different PCRs. And then the serology can just represent, IgM, IgG from the mother. So it's a little bit of a weaker, it's a little bit weak. This is a different study that was, different case report that was published in the American Journal of Perinatology. And this was a 41-year-old G3P2 female at 33 weeks of gestation who basically came in with COVID-19 and was critically ill, requiring intubation. She ended up undergoing a C-section, and the neonate did get intubated because of actually high sedation from the mother. And they had delayed cord clamping, and skin to skin was not performed. And the child was basically immediately separated from the mother and wasn't exposed to any other family members who were noted to be positive. But 16 hours after the delivery, the neonate was noted to be PCR positive, and was also PCR positive 48 hours later. Serology on day 1, as you can see here on the bottom, showed a negative IgM and IgG. And then by about day, negative IgM and IgG. But I think in this case too, this 16 hours from birth, you can't completely rule out the fact that this neonate was exposed to another healthcare worker or somebody who may have had COVID-19. I think the strongest case for possible vertical transmission that I saw was this case report, and this was a 40-year-old G2P1 woman who basically underwent a C-section at 35 weeks and 5 days due to worsening coagulopathy. And she also had COVID-19 at that time. Once the neonate was born, they conducted nasopharyngeal swabs at birth and at day 2 and day 7. And this was positive by RT-PCR. The placental swab was also positive as well, and they also had 5 random sections on the placenta, showed multiple areas of infiltration by inflammatory cells and extensive early infarction. I think, in this case, the neonate was positive on the nasopharyngeal swab at birth, even prior to any contact with the mom or anyone else. So this was definitely a stronger case. So kind of the kind of what we see is that there's limited reports about possible intrapartum and peripartum transmission, but it appears that it can happen, but the extent and clinical significance of vertical transmission is unclear. But it seems like the majority of transmission to neonates really seem to occur primarily through respiratory droplets during the postnatal period, when neonates are exposed to mothers, caregivers, healthcare workers, or visitors. But while I didn't present it here specifically, all the neonates that were exposed and did get diagnosed with COVID-19 all had favorable outcomes. The second possible method of transmission in children is breast milk, and in this case they assessed the breast milk in 3 women. They assessed the breast milk in 5 different women, and as you can see here on the bottom on the red, SARS-CoV-2 was detected in one of the women's breast milk by PCR. In this case, they also examined the breast milk from 2 nursing mothers. In the first mother, on top here, all 4 samples were negative, as marked by this white bottle. But on the bottom, as you can see here, in the second mother, they did detect viral RNA at day 10, day 12, and day 13. And then subsequently, they were negative, and it's kind of marked by the red here. So, COVID-19 and breast milk. So, in most women who tested positive for SARS-CoV-2 in nasopharynx, it appears that breast milk has been negative for viral RNA, but in minority of the women, viral RNA was detected in breast milk. However, what the significance of the detection of viral RNA in breast milk is unclear, but overall, it appears that this is probably an unlikely source of transmission. So the current recommendation on breastfeeding is really to encourage breastfeeding. And if the mother is diagnosed with COVID-19, if there is another healthy caregiver, they recommend feeding of express breast milk until mother is no longer infectious. However, if there is not another healthy caregiver that can bottle feed the baby, then they recommend taking precautions to prevent transmission during breastfeeding to the infant. Now moving on to risk factors. So this is data available from COVIDnet, and the green bars here represent the pediatric population. And as you can see here, obesity and asthma are the most common risk factors that we're seeing. Obesity at 44% and asthma at 17%. But there's really no specific data available that kind of establishes specific risk factors for severe COVID-19 in children. And a lot of the data are actually just extrapolated from adult data or from other pediatric respiratory viruses. And they just pretty much postulate that severely immunocompromised children and those with underlying cardiopulmonary disease may be at higher risk. And children with risk factors that are commonly seen in adults and are known to cause a more severe disease in adults, such as obesity, diabetes, and hypertension may be at risk as well. And now moving on to clinical presentation. So this is the Morbidity Mortality Weekly Report that was published by the CDC back in April that looked at data from February 12th to April 2nd. And they compared the pediatric population to the adult population in terms of symptoms. And what they see is that, the common symptoms that we attribute to COVID-19, such as fever, cough, and shortness of breath, are definitely more commonly seen and reported in adults compared to the pediatric population. As you can see here, fever was seen in 71% adults compared to 56% in the pediatric population. Cough was seen in 80% in adults compared to 54% in the pediatric population, and 43% was seen in adults in terms of shortness of breath, whereas only 13% was seen in the pediatric population. And this is once again the confidence study that was published in New England Journal of Medicine. The percentage seems to be pretty similar, kind of throughout the three countries. With things like cough, shortness of breath, less commonly reported as opposed to like the 80-90% that you would see in adults. The study that was published in the Journal of Pediatrics, as you can see here, about 4% were asymptomatic, whereas 51% were mild disease. And mild disease, they defined it as symptoms of acute upper respiratory tract infection. 38% were moderate disease, with those with pneumonia, with fever and cough. And then 5% were severe disease, and less than 1% were critical disease here. And as you can see here, that I've already kind of, as mentioned, severe and critical disease were more commonly seen among those less than 1. So in newborns, in infants, they were more likely to have severe and critical disease. So consideration for management. So I didn't go over diagnostics in this presentation, particularly because the recommendations of diagnostics is actually the same in terms of who to test in adults versus who to test in children. But the one population that it does differ in is in neonates. So for neonates who are at risk of COVID-19, so whether with their mother being diagnosed at the time of delivery, testing is pretty much recommended for all neonates born to women with confirmed or suspected COVID-19, regardless of whether or not there are signs or signs of symptoms in the neonate. And they recommend that this be performed at 24 hours of age. And if this initial test results are negative, this can be repeated at 48 hours of age. And all neonates who are born to mothers with COVID-19 are pretty much considered as PUIs, and they are isolated from other neonates. And kind of temporary separation of mother from the newborn is recommended in case they are negative. But in terms of just kind of management of COVID-19 in children all throughout, the recommendation is, pretty much symptomatic and supportive care with supplemental oxygen or ventilator support, electrolyte or fluid support, and empiric antibiotics if secondary bacterial infection is suspected. Currently, there is insufficient data to recommend for or against the use of specific antivirals, but remdesivir has been currently remdesivir is available through emergency access program for children. And overall, and finally, the outcome, as you probably have heard, the outcome is pretty favorable among all children. And as you can see on this slide, nearly all children with COVID-19 survived. And here, there was one that was reported in the Chinese study, and then 3 in the US, according to the CDC data. But how much COVID-19 contributed is it wasn't very clear in the literature. Finally, moving on to multisystem inflammatory syndrome in children. Just kind of overview on Kawasaki disease. This is one of the most common vasculitides in childhood. And it's basically widespread inflammation of the primary medium-sized muscular arteries. There's systemic inflammation with signs of fevers associated with mucocutaneous inflammation. So children have signs of like non-exudative conjunctivitis, erythema of the lips and oral mucosa, and the term strawberry tongue that we commonly saw in our step 1 way back in the days, as you can see in this photo. There's rashes, extremity changes, and cervical lymphadenopathy. So this kind of Kawasaki like disease has been reported in children during the COVID-19 pandemic. And the first report of this possible multisystem inflammatory syndrome in children emerged from the UK in April of 2020 and was published in the Lancet. And here there's been kind of varied presentation, but the common pattern here is that basically all of them actually have prolonged fever, kind of followed by rash, conjunctivitis, peripheral edema, and GI symptoms, and all progressed to vasogenic shock, requiring vasopressor support and volume resuscitation. Surprisingly, most had no significant respiratory involvement. They had high inflammatory markers with things like high CRPs. And actually, at the time of their illness, all 8 kids tested actually negative for SARS-CoV-2. All were given IVIG. One died, and then 2 actually ended up testing positive for SARS-CoV-2. One was upon discharge, after discharge, and then one was actually found post-mortem. And since then, this kind of multi-system inflammatory syndrome has been reported kind of throughout the world, with children affected in the US, Europe, and Canada, and things like that. And in this study that was published in the Lancet early this month, it's basically showing that there's kind of an increasing number of Kawasaki-like disease that's been reported since this SARS-CoV-2 epidemic, as you can see here in 2020. And as more and more data are kind of coming out, what we see is that COVID-19 has like a spectrum of disease in children. In most children, the COVID-19 causes no or mild symptoms, no or only mild symptoms, with pretty much minimal exaggerated immune response. But as you progress, there's kind of febrile inflammatory state where children kind of present with persistent fevers and mild symptoms and elevated inflammatory markers, but lack the kind of the multi-system involvement. Then children can develop COVID-19 associated Kawasaki disease-like illness, where kind of they meet the criteria for complete or incomplete Kawasaki disease with kind of, mucocutaneous inflammation and things like that, but they don't actually develop shock or multi-system involvement. And in rare cases, COVID, there can be multi-system involvement, where they have this severe presentation with markedly elevated inflammatory markers and multi-system involvement, commonly with cardiac involvement. And there's been various definitions for multi-system inflammatory syndrome in children that's been kind of thrown around, and there's actually different ways of diagnosing it based on the WHO criteria or the UK criteria or based on the CDC criteria. But for CDC, they basically, case definition is defined as like an individual aged less than 21 years old, presenting with fevers with lab evidence of inflammation and evidence of clinically severe illness requiring hospitalization with multi-system organ involvement, and no alternative plausible diagnosis, and positive for current or recent SARS-CoV-2 infection by PCR, serology, or antigen test, or COVID-19 exposure within the 4 weeks prior to the onset of symptoms. Overall, kind of the data on multi-system inflammatory syndrome in children are actually like kind of coming out, and this is actually a study that was published 2 days ago in JAMA. This was a case series of 58 children from 8 hospitals in England that was admitted between March 23rd to May 16. I don't actually go over the data here, but they actually compare it to Kawasaki disease or Kawasaki disease shock syndrome or toxic shock syndrome that were diagnosed actually at Rady's Hospital and in European hospitals between 2002 and 2019. But what we overall know is that there's kind of an unknown incidence, but the general agreement is that it seems to be overall not as common, and that the epidemiology really does seem to differ from that of classic Kawasaki disease and acute COVID-19. As you can see here, for multisystem inflammatory syndrome, um, the, um, the median age was about 9 years old. Uh, um, Median age was about 9 years old, and this is actually older than those who will generally who would be affected with Kawasaki disease or Kawasaki disease like shock syndrome, and Kawasaki disease tends to affect more East Asians. However, here in terms of ethnicity, 38% were Black and 31% were Asian. In terms of symptoms, 53% developed abdominal pain and diarrhea, and other signs and symptoms include rash, conjunctival injection, mucous membrane changes. And this chart on the right kind of represent kind of accumulation of data from not just this study, but other studies as well. Persistent fever, which is actually one of the diagnostic criteria, is seen in 100%, and other common symptoms included GI symptoms, rash, and conjunctivitis. And interestingly, as I mentioned in the prior, in the initial study, many have negative PCR but positive serology. So in this study, only 26% were positive by PCR, but 83% did have positive IgG. So the kind of the postulation behind, they hypothesized that that this isn't actually related to acute COVID-19, but that this may actually be related to immune dysregulation occurring after the acute infection has passed. And otherwise, in terms of other lab findings, there's evidence of marked inflammatory state. So what you see here is high CRP and high ferritin levels. Some other findings are, lymphocytopenia, neutrophilia, elevated D-dimer, elevated procalcitonin, and elevated IL-6 levels. And then there's been elevated cardiac markers that's been reported, and as I will, this can also affect the heart, with 68 to 95% showing elevated troponins and 78 to 100% showing elevated BNPs. In terms of imaging findings, about 31 to 58% had depressed LV function, whereas 14 to 48% had coronary artery dilation or aneurysm. In terms of chest radiograph or chest CTs, it was actually normal in many patients, and in a minority of patients, they have like small pleural effusions or patchy consolidation, but pulmonary findings do not seem to be a major thing. And abdominal imaging has been performed since a lot of children have complained of abdominal pain, and what they see is some free fluid or ascites, and bowel and mesenteric inflammation, including terminal ileitis, and mesenteric adenitis has been seen as well. In terms of management, so IVIG is the treatment for Kawasaki disease. And in this study, about 70% of the children were treated with IVIG, with others treated with corticosteroids and IL-1 antagonists and TNF-alpha antagonists. So here, in terms of just kind of general broad strokes in terms of management, there's kind of unclear role of antiviral therapy like remdesivir. And as this is likely to represent more like a post-infectious complication rather than an active infection. But it is something that can be considered. IVIG has been recommended, as I mentioned. Steroids has also been considered, and they recommend that you consider it for patients with features of Kawasaki disease who have persistent fever after IVIG, or coronary artery dilatation or aneurysm. IL-1 inhibitors can be considered for those who can't receive steroids or those who are refractory to steroids, along with IL-6 inhibitors as well. Kind of the benefit and risk of convalescent plasma are uncertain as well at this point. And in terms of just kind of outcome in children with multisystem inflammatory disease, so they among 58 children, 1 died. There were 8 that had coronary artery aneurysm. So overall, it's most do survive. Majority do survive. So in summary, children appear to be affected less frequently and have milder disease in adults, but in rare instances, children can be severely affected with multisystem inflammatory syndrome. There's uncertain prognosis, although current data, seem to indicate that most children do survive and do well with evolving understanding of the disease. And there needs to be further research on kind of adjunctive therapies with things like steroids and IL-1 and IL-6 inhibitors and convalescent plasma. I don't go over this here specifically, but prevention strategy is obviously the same as here, as it will be in adults, with focus on hygiene and social distancing. So thank you for listening. And this is a photo of my 6-month-old who motivated me to learn more about this topic. And I'll take any questions now.
Minji, thank you so much. Oh my God, she's adorable. Well, the chat has been pretty quiet. I'm gonna open it up if anyone wants to unmute themselves and ask a question. Or certainly you can send it in the chat now that I'm happy to read to Minji.
Hi, it's Miley. Mindy, that was great. Thank you so much for that summary. Certainly a lot of us are already experiencing the impact of having children at home, not just, to our careers, but also to our personal lives in the sense that we can't ever escape our family. But this is concerning. I think a lot of us are hoping and waiting for some sort of preventive measure for children to be made available so that we know that we can send them safely to school, since many of them are incapable of keeping their mask on or socially distancing, no matter how well we educate them. What are your thoughts, especially regarding the hyperinflammatory syndrome, about how we would approach vaccine development, what things we need to be worried about, etc.?
Yeah, that's a great question. I think in children, it needs to be balanced with, I think while the data currently available on children are more reassuring compared to adults, we don't really have, clear studies on that show like kind of what kind of role do children play in terms of transmission or anything like that. So there's definitely needs to be more work done, and it also needs to be balanced with kind of the effects of social distancing that has on children in terms of kind of their social development and lack of schooling. And there's also there's vulnerable children who are in foster care systems and things like that, where this can have severe impact on them. I didn't really come across much on vaccine development in children, except that, there's just been kind of editorials regarding it, just stating the importance of vaccination in children. And even though they may not kind of play a big of a role as they would in adults, in terms of disease and things like that. Was there a second part to the question? I forget.
Oh, no, I think I'm just interested in knowing how people would approach vaccination, because, will this increase risk for having this Kawasaki-like syndrome? I think that there's just a lot of unknowns. I'd love to hear, I don't know if Sydney's on the call. I know she's our resident expert in COVID immunology or coronavirus.
Yeah. Doesn't seem like Sydney's on the call.
Sydney. Yeah, exactly.
Yeah. But there hasn't really been much information, regarding vaccination as of yet, that focus on children specifically. Yeah.
There are a couple of comments in the chat, Minji. Can someone comment on counseling isolation of newborn immediately postnatal in mothers who test COVID positive?
Yeah, so currently it's recommended that they be separated, and obviously if the neonate does come back PCR positive, then they can be reunited again. But while the mother has acute disease and are symptomatic and likely should be shedding virus, they recommend separation between the neonate and the mother.
Nettie made a comment. I'm actually not sure what the acronym is. Nettie, can you unmute yourself? I don't know if you're able to.
I'm here. What did I say? Let's see.
MSI-C.
Oh, multisystem inflammatory in children.
Oh, wow. Okay. There you go. Do you want to?
I finally learned it, so I was using it. But
no, that's smart. Thanks. Sorry. Yeah, I don't know if you want to make a comment, Nettie, or you were just sort of.
No, I just, I think we're very, as doctors, we're so interested in new things, new viruses, new syndromes, and they get a lot of press, and that's important, and for academic and education and whatnot. But, we have thousands and thousands and thousands of real data points on real harm for children being at home, domestic violence, substance abuse, lack of social stimulation, depression, internet porn, you name it. There's a lot of real identified risks of children being out of school. And we get so excited about the other risk that's new and exciting. And then we have been sort of ignoring all these risks right in front of us of keeping them out of school. So, to Miley's point, it is nerve-wracking to worry about something new that could harm kids. But, just putting it in perspective of how many kids get Kawasaki disease from, the usual viruses that we've been exposing them to when we send them to school previously, and this particular one has fairly minimal impact on children in general. And so I would like us to help the rest of the world weigh the risks and benefits in a better way so that we can, do what's best for kids and not necessarily feel so focused on these less common risks and ignore the big risks in front of us, which is something that doctors, have to do we have to help our patients with that all the time, right? I'm really afraid of this thing. Oh yeah, but let's really focus on your diabetes and your hypertension.
I think that's a great point, Nettie. I think the part that worries me, and Minji mentioned it just now, was just sort of what's the role of children in transmission. So it's less that, for me, it's less that children get sick and get really ill, because it looks like that is a pretty small risk overall. It's who are they passing this infection to, and then who's getting sick from that. And we just have so little information on that. As things are opening up and people are, daycare centers are open now and camps are opening for the summer, will we see this next wave? And again, I don't mean to say it's less about the children, because of course it's about the children, but it's, what impact does their, getting infected have on the people around them and the people who could really get ill.
Yeah, I'm going to just push back a tiny bit though, because I feel like we've been saying we don't know, which confuses a lot of people. But actually, we do know some things, right? We're not completely in the dark here. So there have been a couple modeling studies on the impact of closing of schools, and there have been, studies looking at, do children transmit, and mostly they're getting it from their household. They're not the ones transmitting to the household. So everything is a gamble, but because we are it's not a random gamble. It's not like we have no idea, so let's just wing it. It's like, no, we have some data now. We slowed down and now we have some data. And, as doctors, when we do risk benefit analysis, it's our job to help patients, look at the risk in front of them, and then also all the other risks. Like, okay, let's think about both your, not just the shark attack you're worried about today, but also the diabetes, the hypertension, the alcohol, So I feel like for COVID, I don't want to contribute to a new wave, any more than anybody else, but there are a lot of known harms to kids that are actually happening. And so weighing those against this theoretical worry, and then just saying, well, we have no idea, so let's keep them locked inside. But we do have some ideas.
I'm gonna push back though. I don't understand how modeling, when everything closed, I'm unaware of how modeling studies would be able to distinguish between this closure versus this closure in terms of.
They exist. I'll send them to you. There's, they look at
that would be wonderful.
Yeah. I have a whole list.
Okay,
great. The other point I think that Net is trying to make is that it goes two ways, right? So if a child gets infected, of course, you want to take care of that child. But if you have a family member who's at higher risk of complications, maybe you will want to just tell that family member that they stay away for the first, 3 weeks that the child returns, that they keep a distance, and that they mask at home, right? So that we have now multiple possible protections, and it doesn't mean that letting kids return to school in a very thoughtful manner, puts us at the same risk as we were before, because we were not doing a lot of things that really will mitigate the spread of the virus.
All very good points. Looks like the chat has quieted down. You got a lot of praises, Minji. And I will also say congratulations on finishing your last presentation as a fellow. Unfortunately, they keep making you give presentations as you move into other aspects of your career.
So I've heard.
But this was great, Minji. And just for those who are wondering, Minji's off to UT Southwestern to continue her very bright career in infectious diseases. So we're sad that she will be leaving us, but know that they are gaining someone wonderful in Texas. So thanks, everyone. You get 12 minutes back in your day. And thanks so much.